everyone, depending on your time zone. I'm Dr. Giulia Belluardo, a psychologist and PhD student in human sciences at Gugliemo Marconi University in Rome. Before my PhD, I worked with the haemodialysis patients, and this population does not usually receive much attention from the scientific community. And several years ago, I realized that there were many questions surrounding the cognitive health of hemodialysis patients. So I began conducting research in hospitals in nephrological department, and now I'm pleased to present this small contribution on cognitive decline, sleep disturbances, and associated pathological factors in these patients. So, before going into the heart of the matter, it is worth defining what we mean by hemodialysis patients, and we can do this by starting with the definition of chronic kidney disease, or CKD. Chronic kidney disease is a pathological condition characterized by persistent reduction in glomerular filtration rate, by increased urinary excretion of albumin, and the presence of functional or structural abnormalities of the kidneys. A review of literature shows that chronic kidney disease is a disease with a rapidly increasing global prevalence. This increase in prevalence makes CKD a public health issue that requires urgent attention and clinical and experimental efforts. To better understand this condition, it is necessary to describe the different stages of the disease. Chronic kidney disease consists of 5 stages. The first stage has a glomerular filtration rate around 90, and the kidneys show moderate damage, but they still function well. The second stage is characterized by a glomerular filtration rate ranging to 60 to 90, and the kidneys have mild damage with a slight decline in function. The first stage is characterized by a glomerular filtration rate ranging from 30 to 60, and the kidneys show moderate damage and loss of function. This stage is often divided into 3A and 3B, based on specific eGFR ranges. The fourth stage is characterized by glomerular filtration rate ranging from 15 to 30, and the kidney showed severe damage in this stage. Significant physical symptoms begin to appear, such as nausea, vomiting, loss of appetite, and difficulty concentrating. And finally, the fifth stage, also called end-stage renal disease, is characterized by a glomerular filtration rate of less than 15. The kidneys in this stage have failed or are very close to failing. Dialysis, hemodialysis, or peritoneal dialysis, or when applicable kidney transplant, is required to survive. From the description of these 5 stages, it is clear that dialysis patients have a long medical history behind them, and that this history continues with hemodialysis therapy. Hemodialysis is a type of renal replacement therapy that uses an extracorporeal circuit. In a nutshell, we can say that hemodialysis removes excess fluids, purify the blood of waste substances, and maintain homeostasis. This therapy must be performed 3 or 4 times a week, depending on the specific case, and for 2 and 4 hours at a time. This type of therapy is physically and psychologically very, very stressful and is associated with many complications that hemodialysis patients have to deal with every day. Among the many complications, I will focus on two today: sleep disorders and cognitive impairment. We know from scientific literature that CKD and HD sorry, are associated with a high risk of cognitive impairment, but which domain are most affected? The literature shows that the most affected domains are executive function, memory, attention and orientation, and processing speed. We also know from scientific literature that CKD and HD are associated with high risk of sleep disorders. In particular, the prevalence of sleep disorders increases depending on the stage of kidney disease. Patients with chronic kidney disease who are not yet in terminal stage have a prevalence of sleep disorders of around 50 to 70%. Meanwhile, patients in terminal stage undergoing hemodialysis therapy have a prevalence of sleep disorders ranging from 75 to 80%. In particular, insomnia, restless syndrome, and obstructive sleep apnea are the most common disorders in chronic kidney disease and in the patient undergoing hemodialysis treatment. Sleep quality is reduced. Rapid eye movement latency increased. Stage 1 sleep, reduced stage 2 sleep, and only improves after the first 6 months of dialysis. But why? And what are the factors associated with these two complications? Let's us being said that specific factors associated with cognitive impairment in CKD and HD have been identified, and that among these the most significant are altered cerebral and carotid hemodynamics, CKD and HD traditional and non-traditional risk factors, and intradialytic hemodynamic instability. Let us examine cerebral and carotid hemodynamic alterations. And a study we conducted a few years ago and published it recently supports this association. In particular, we examined the cerebral hemodynamics of hemodialysis patients using transcranial Doppler or TCD, which is a non-invasive, fast and safe technique for the patients, and carotid hemodynamic using supraortic trunk Doppler ultrasound or SET, which is also a fast and non-invasive examination. We simultaneously assessed cognitive function using neuropsychological tests such as MoCA or Montreal Cognitive Assessment for a quick and comprehensive assessment of cognitive functioning, trail making test A and trail making test B for processing speed and attention, and the frontal assessment battery for executive function. The results of our pilot study tell us that hemodialysis patients have a decrease in mean flow velocity, an increase in vasoreactivity, especially in the right side of the brain. Furthermore, we found a negative correlation between mean flow velocity and trail making test score, indicated that cerebral hypoperfusion is linked to executive function impairment. Finally, SET showed an increase of intima media thickness and the presence of plaques or aspects associated with cognitive scores. Second factor, intradialytic hemodynamic instability. On this topic, many studies show that hemodynamic instability is a very common in hemodialysis, with marked variability linked to population, definition, and stage of therapy. The prevalence of intradialytic instability ranges between 20 to 50% of patients on hemodialysis. And also, the risk of hemodynamic instability is highest at the start of therapy, particularly during the first hour of the first hemodialysis session, often even in the absence of ultrafiltration. The incidence in this phase is significantly higher than in subsequent session. Third factor, traditional and non-traditional risk factors related CKD, HD. We know that hypertension, diabetes, dyslipidemia are the main vascular risk factors, and these are among the traditional risk factors for cognitive decline. Uremia, oxidative stress, and chronic inflammation, hyperuricemia, secondary anemia, and electrolyte imbalances aggravate brain damage. And these, on the other hand, are non-traditional risk factors related to CKD and HD. Now, let's move on the specific factors associated with sleep disorders in CKD and HD. We have neurovegetative and hormonal imbalances, dialysis-induced vascular stress, and systemic inflammation. In this case, our narrative review examined the factors associated with this disorder in depth, and we were able to obtain 3 macro categories of factors. The first category refers to neurovegetative and hormonal alteration, and in particular, among the various factors we mentioned, frequent sympathetic vagal dysfunction, such as sympathetic hyperactivity, reduced vagal tone, that alters sleep regulation. And then melatonin, that is significantly reduced in HD patient with loss of their nocturnal peak, compromising the circadian rhythm. Parathyroid hormone, or PTH, elevated levels predict poor sleep quality, and in some cases, parathyroidectomy may improve insomnia. Then vitamin D, deficiency of vitamin D related to reduced sleep duration and nocturnal awakenings, and supplementation of vitamin D is a promising strategy. Cortisol, increased in increased in approximately 50% of patients with CKD and undergoing hemodialysis treatment, and this contributing to nocturnal arousal hyperactivity. The second category refers to dialysis-induced vascular stress, in particular reduced mean flow velocity and hemodynamic alteration hinder cerebral metabolic cleaning during non-rapid eye movement sleep, worsening sleep quality. And sleep quality is better in patients undergoing peritoneal dialysis, where vascular stress is lower because peritoneal dialysis is more physiological than hemodialysis. Third third category refers to the systemic inflammation. In fact, we know that inflammatory conditions are associated with daytime sleepiness, reduced deep sleep, and poor overall sleep quality. This table summarizes the factors that cognitive impairment and sleep disturbances have in common in this population. And we can immediately see that vascular and hemodynamic damage affect both aspects, as do inflammation, vitamin D deficiency, autonomic imbalances, and hormonal disorders with melatonin, PTH, and cortisol. Before concluding, I would like to present some therapeutic perspectives that may help patients and improve their quality of life. First, let us distinguish between pathological intervention, non-pathological intervention, and integrated approaches. A review of the literature revealed that some pharmacological intervention may have potential. This included exogenous melatonin to improve sleep quality and regulate blood pressure, dopaminergic agents for restless syndrome, blood pressure control with antihypertensives, prevention of hypotension, to reduce vascular damage and slow cognitive decline, and vitamin D supplementation for benefits to both sleep and cognition. Non-pharmacological intervention include sleep hygiene through relaxation techniques, cognitive behavioral therapy for insomnia, or aromatherapy, massage, listening to music before bed. Physical activity. We know that regular exercise, aerobic exercise, can improve cerebral perfusion and sleep quality. And intradialytic cognitive training that can enhance executive function and cerebral blood flow. And finally, there is initial evidence on some positive effects of transcranial direct current stimulation that can improve spatial working memory and frontal plasticity. I conclude with integrated approaches, understood as the combination of multidisciplinary programs that include hemodynamic monitoring with transcranial Doppler or SET, with neuropsychological assessment, using Montreal Cognitive Assessment, of Frontal Assessment Battery, or Trail Making Test, and other neuropsychological battery, and sleep assessment with questionnaires such as Pittsburgh Sleep Quality Index or polysomnography. And these multidisciplinary programs allow for the early identification of patients at risk and the implementation of targeted strategies. And thank you for your attention.